Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day. Hi, all you BTK listeners. It's Scott here. Want to talk a little bit about our colorectal surgery oral board audio review. With upwards of 50 plus high yield scenarios designed for colorectal surgeons by colorectal surgeons. The scenarios are 5 to 7 minutes long, a variety of tactic styles. We also have a high yield commentary to each scenario. It includes tips and tricks that help you dominate the most challenging scenarios, in addition to practical, easy to think through, easy to understand teaching style that covers the most confusing, the most interesting, and the most basic of topics that we all face as colorectal surgeons. So we are confident that you will find this unique, dual format approach highly effective way to prepare for your test. Check it out, behindtheknife.org.
Hey everyone, and welcome to Behind the Knife. My name is Elissa Dabaghi. I'm a general surgery resident at the Cleveland Clinic.
And I'm Hendren. I'm a general surgery resident at Cleveland Clinic as well.
My name is David Rosen. I'm the section head of the Division of Colorectal Surgery at Cleveland Clinic Fairview Hospital.
I am Ajaratu, also known as Ajaratu Keshinro. I'm one of Dr. Rosen's partners.
And I'm Joseph Trunzo, also one of the partners here at Cleveland Clinic Fairview and Associate Program Director for General Surgery Residency.
All right, so today we're tackling one of the most challenging complications in colorectal surgery, anastomotic leaks. Our discussion will focus on how to manage them both in the OR and post-op, and some practical decision-making tips that can help surgeons navigate these high-stakes situations. So let's start with the case. We have a 50-year-old man, history of recurrent sigmoid diverticulitis. His last episode was 6 months ago, and he's been symptom-free since then. And he sees y'all for an elective laparoscopic sigmoid colectomy. Intra-op, there's no signs of acute inflammation, although the sigmoid's a little thickened, and you ultimately perform a stapled end-to-end colorectal anastomosis without tension or difficulty, and your intra-op leak test was negative. On post-op day 4, he's mildly tachycardic to 105, his blood pressure stable, systolics 145, afebrile, he's passing flatus, having some liquid stool, he's tolerating his diet, but having some mild left lower quadrant abdominal pain. We get some labs, his white count's 14, which is up from 10, and CRP's 190. So what do y'all think of this presentation?
Well, given the title of our talk here today, I would be worried about an anastomotic leak here. I think, that's kind of the thing that as colorectal surgeons, we always worry the most about, especially in this kind of a range. There's early leaks and there's some later clinical leaks, and this seems to be on the earlier side. But with the tachycardia, the labs, and some abdominal pain, some kind of intra-abdominal process is on my mind, whether it's an anastomotic leak. Could you have something like a internal hernia that got incarcerated, or some other kind of intra-abdominal finding? And I think the way to elicit this workup is a CT scan of the abdomen pelvis with IV contrast. If the patient were also hypoxic and you were worried about a PE on your differential, you could also add in a CT-PE and kind of do one round of contrast and get a chest abdomen pelvis imaging. But my workup would be a CT abdomen pelvis with IV contrast. Personally, I don't use rectal contrast in these patients. From a theoretical standpoint, I worry about inserting the contrast, and if there is a small leak, making it worse. And usually you can see the inflammation around the rectum and any fluid collections with just the IV contrast, and it doesn't change my management. But I know there are many people who typically do rectal contrast in these, but I'm not one of them.
Yeah, in my residency, we used rectal contrast a lot. In fellowship, we didn't, and now in practice, I don't anymore. But I think it could be very helpful in situations where you're trying to decide if the patient, because someone like this is pretty stable. I mean, all the signs are very subtle. Honestly, clinically, this patient, I'm probably still watching, right? Mm-hmm. But if you're worried about a leak, I think a CT contrast can be helpful in this case, where if you see a collection and you can't tell if he's actively leaking out or not, and what you want to do with the situation, I think if you see contrast extrav, that could be very helpful to know that this is something that's just started, for example, and potentially can get worse. So I think it can add some helpful information and give you a little more of a dynamic information.
And I'll concur with Dr. Keshinro about it is kind of a subtlety right now. I'm not sure if I'm ready to do something diagnostic at this point, or if his exam really has significantly changed. I think if his exam has significantly changed from what it was the day prior, and he's all of a sudden more pain, having more tenderness in the setting of these other objective findings, the tachycardia and the leukocytosis, then I think it would probably push me more to getting some radiographic imaging about what may be happening at your abdominally. And as far as the contrast, I tend not to use rectal contrast for the same reasons Dr. Rosen described, and I think I'm able to generally gather the information we're looking for, whether it's a contained leak or a non-contained leak. I think one of the issues you're going to have here is there's probably going to be some air intra-abdominally extra that you're going to have to decide whether that's post-operative versus something that's actually clinically significant. And if you're going to have a little bit of subtlety to deal with there.
Yeah. And not to advocate for rectal contrast, because again, I don't use it, but I think that's also where I find it helpful, because laparoscopic surgery, there's going to be post-op, and I think sometimes just seeing that contrast could give you extra information that prompts you to do something about it, depending on how the patient is clinically.
All right, great point. So we get a CT with IV contrast, no rectal contrast, but it did show a 3.5 centimeter presacral fluid collection with a small foci of gas. So given this radiographic presumed potential leak, especially since the patient is clinically stable, how would y'all approach managing this patient? Like, what factors help you decide whether to operate or to continue non-op management? And when you're in the OR, how do you decide on the best strategy?
So I'll start with, in a situation like this, I think, the patient's clinical condition is really going to impact, your ability to do certain things. If the patient is showing signs of severe sepsis or goes down the road of shock, then that's going to be someone that's going to push you to the operating room. But as he's presenting with this sort of scenario of, some subtle signs of SIRS, leukocytosis, increasing abdominal pain, and what looks like potentially a contained leak or, contained perianastomotic collection, I think you can attempt to try to drain it, try to manage it non-operatively with potentially interventional radiology, draining that collection and seeing if you can control this situation without another reoperative procedure.
I agree with Dr. Trunzo, and I think the other thing that also matters is the patient's overall health status, comorbidities, meaning that can they tolerate non-operative management and, with a drain and antibiotics, because sometimes the sicker patients don't have much of a reserve that you actually want to be a little more aggressive about managing it so that you don't get into trouble.
Yeah.
Yeah, I agree. I think, anastomotic leaks are one of the things in colorectal surgery that our management strategy is overwhelmingly dependent on the patient's clinical status. If a patient is clinically stable, not showing signs of severe sepsis, hypertension, peritonitis, then it is very reasonable to pursue a more conservative or non-operative strategy. Because if you take this patient back to the operating room, you really are guaranteeing them an ostomy of some kind within the operating room. But that being said, you do have to find a way to control the infection. So for me, for this patient, I'd look at oftentimes these presacral collections are very difficult and challenging for our IR colleagues to drain in terms of having a suitable window without bowel being in the way. Sometimes there's some transgluteal locations that they can get to. But if they're unable to drain it, then I think starting with IV antibiotics and watching very closely to see how the patient does is a reasonable first approach, because this thing has sealed off or is a contained collection, because if it was not, the patient would be very sick. There'd be stool leaking out.
Yeah. And to answer your question about intra-op decision making, someone like this, if I do end up taking to the operating room, the first thing I'll put a camera in laparoscope and take a look around the belly, kind of see what this fluid is in the pelvis. Yeah. Is it abscess? Is it stool? And then at the same time, also get endoscope. So when you're taking someone like this back, you should put them in lithotomy, have a flex squaredoscopy ready to go so you can interrogate the anastomosis and test it as well. Sometimes something like this is a very subtle, small finding that you might not see with a laparoscope, but by doing a leak test, you will see that there's a leak, and you can repair it. And something like this, I would personally divert. I would not be comfortable just repairing it and getting out of there. I don't think anybody would. But
I think that would be an error technical error if you took the patient back, you identified he had a contained leak, or even if it was an uncontained leak, and primarily repaired that leak and didn't divert that. I mean, I think you're setting yourself up, and really you're setting this patient up for a failure, because that will invariably fail because you haven't given any relief to the problem area.
Joe, I've heard you so many times teach the residents really well about your options of what to do intraoperatively when you go back and there's a colorectal anastomotic leak. Can you walk us through, say, the patient was a little bit sicker and forced your hand to go to the operating room. You find say a 1 centimeter anterior defect of the colorectal anastomosis intraoperatively. Walk us through, because you teach it so well, walk us through what are your options and what would drive you personally to each of those options.
So, I think it comes back to what you mentioned earlier about the patient's clinical condition. If you're taking this patient back and they're in septic shock, this may not be the patient you're going to be able to salvage that anastomosis. And if it's sort of a very damage control situation, you can take that anastomosis down and bring up an end colostomy to preserve the patient's, life or limb. If the patient is in a relatively controlled situation and you have what looks like a repairable anastomosis, you could oversew that anastomosis with a proximal diversion, with diverting ileostomy, and that would be your other alternative. The one time you might actually resect it and revise it, that's a very select few patients, and there's not a lot of good. I wouldn't feel comfortable with doing that in most situations. If I'm going to take down that anastomosis, I'm probably not going to reconstruct it at that time. And I'd be more apt to give them an end if I'm going to take down the anastomosis. The one time, if we're not talking about an anastomotic leak in the post-op period, if we're in the intra-op phase and we got a positive leak test during the first creation of the anastomosis, I might take it down, redo the anastomosis, and not divert, as if this is a brand new primary colorectal anastomosis, and it wasn't exactly related to some form of sepsis or infection, and it's more of a technical problem, and we were able to revise the whole anastomosis and redo it without proximally diverting. So those are that would be probably my most common iterations. And you also want to remember, you also would typically drain the pelvis. So if you haven't left a drain, and most of these elective sigmoids wouldn't have a drain, you want to leave a drain in case it does still break down, so that you have some form of control of that leak, and maybe you have a controlled fistula, though you are diverted proximally, so you don't have ongoing fecal contamination into the pelvis. So that's probably, I guess, the algorithm that I would describe to the residents. And I think it really is, your options are more when you have a patient that's relatively stable. And preserving an anastomosis is important. And I guess I can add one other thing, not to go off too far on a tangent. And the other thing that you would want to do that would also push me to try to preserve the anastomosis or repair it is also how low it is. If this is a low colorectal anastomosis, like for, say, a rectal cancer, you may not have much left to preserve that patient's GI continuity. So repairing the anastomosis really may be the patient's only option to preserve that, their ability to be able to have continuity. And taking it down completely and giving up an end basically may burn that bridge forever happening again. If someone is getting a sigmoid and they have their entirety of the rectum still there, you still have the option of taking it down.
Yeah, that's some really great insight. So, okay, let's say the same, scenario, the same patient was already diverted at the index case. You diverted them intra-op and the leak test was negative, but post-op day 4, they present the same vague symptoms and you're concerned for a leak. What do you do in this scenario? The patient's clinically stable, but they're already diverted.
So I think, patients I like the idea of this discussion of anastomotic leak with a diversion, though I will say most patients that are diverted, very rarely would they present with huge symptoms, presuming they got, preoperative bowel prep and there's not a lot of stool there. But for the sake of discussion, this is a great scenario. So if you're diverted already, you're kind of in a great place to try to do something to fix this. And it's often best, I would say, this is the right time to do something not operatively, but endoscopically is kind of where I would lean towards doing this. So say you get your workup, you're concerned for an anastomotic leak. You want to, and I'm stealing Dr. Trunzo's thunder here because he says this a lot, and I think this is a great point. You want to get control of both sides of the anastomotic leak. So if you diverted them, you left a drain in the pelvis, because oftentimes if you're concerned of divert, maybe there was a reason you would have left a drain. then you're kind of controlled on the outside of the anastomosis, on the peritoneal side of the anastomosis. If you did it, then though, and you had some kind of fluid collection, then I would try to find a way to get some type of percutaneous drainage from the outside. And then endoscopically, I think this would be, this would be a great time, since you're already diverted, to try to take a look and see what the defect looks like. If it's a small defect that can be closed with some type of endoscopic clip, or one of those big bear claw clips are often very effective in those over the scope large clips. Those are oftentimes can be effective to get this. But some of it depends on what the tissue quality is like too. If you're getting in there and you're looking endoscopically and it's like wet tissue paper, not much is going to hold. There are patient factors that matter too. If the patient had received radiation, you're in a much tougher situation than if they did not. So, there's patient factors that come into play, such as comorbidities. There's things that they've gotten before, like radiation, and there's tissue quality, and all those kind of come into play. But in this situation that you devised, I would try to be doing something endoscopically to close it up, since I'm already diverted.
Good point. Yeah, so I guess can you all briefly touch on when you pursue percutaneous versus transrectal drainage, and with that pre-sacral collection? And I know you touched a little bit on the endoscopic management of these anastomotic leaks, but are there any thoughts on endovac, suturing, the closure success rates with those methods, or?
I will tell you, I have not had a lot of experience with the endovac. I know it's being done, but those are more commonly utilized in situations where we have a low rectal anastomosis, where you can kind of get to that. A high rectal anastomosis is going to be very hard to control with some kind of transanal rectal, whether it's a vacuum or even transrectal drainage. We've done that too, where you've actually placed some type of mushroom or malacot drain through a transanal approach into a presacral cavity. Like Dr. Rosen said, sometimes it's difficult to get our radiology colleagues to get into that plane, but we can run a drain into there to collapse that cavity and control the sepsis. It's not the most pleasant experience for the patient by any means to have a drain transanally, but that is a means to control your presacral collections when you have them in this position. Something intraabdominally, usually you can get some kind of interventional radiology drain.
Yeah, you can, the endovacs, are something that we do use. It's not commercially available here, I think, yet, still in Europe, but you can jerry rig one and do it. It requires, at least 2 changes a week in the operating room, and we use them sometimes for these very low leaks where you don't have other options. I'll say as a final option that is used very sparingly, and we talk about here at Cleveland Clinic often, is a turnbull cuttae. If you have someone with a very low leak, you can do a pull through with a delayed coloanal anastomosis a week later. The function, I will caution, is not that great afterwards for these patients, but it is a way to try to gain some GI continuity for these patients with really difficult problems.
All right, those are great insights. So lastly, kind of wrap this up, are there any concerns that you look out for down the road with these anastomotic leaks that you manage expectantly? Like what are some things you're worried about or looking for? And then thinking even more ahead, when do you consider reversing patients that are diverted, and any workup involved in that decision making?
So in situations with the smaller leaks that you just ended up repairing and diverting, I think those are usually a little more straightforward. Just wait in about 6 to 8 weeks and get a contrast enema test to see if there's any evidence of ongoing leak. I think it would be appropriate before you reverse such a patient. I think the patients also where you ended up taking down the anastomosis and giving them a colostomy are also easier to manage. I think the situations that can be very difficult to manage are the ones where they have chronic ongoing leak and then develop a sinus, and then they can take a very, very long time to heal. You end up, taking them for exams or endoscopic evaluations where you try to debris the cavity, waiting for it to seal. I think sometimes those situations can be hard to salvage. And even if you do salvage them, I do think they can end up with a lot of functional consequences in terms of their bowel habits and, from that standpoint. So I think if there's a chronic sinus tract that doesn't heal, you have no choice but to eventually go back and do a redo, like resection and redo anastomosis, potentially divert them at that time as well. So I think that's the way I would think about it.
I think anytime you have a compromised anastomosis, you have to be concerned about the potential for stricture formation at that anastomotic site. Mm-hmm. So part of that gastrographin enema or contrast enema that you're going to be doing, you're going to want to assess that anastomosis. It may demonstrate on the enema test, but you also probably endoscopically you want to look at that anastomosis, because invariably when an anastomosis has been revised in some way, related to a leak or a controlled leak or even a repaired leak, they have a high incidence of stricture formation. Before you reverse that diverted stoma, you have to be sure that you've assessed for that, because that operation may again require you to revise and redo that anastomosis, because even though you thought you salvaged it, it may not be a salvageable long-term solution for this patient. So, and you do now, obviously, the worst situation you could be in is reversing the ileostomy and had not fully assessed that anastomosis and find out it was stricture. And then you really have put this patient in a very difficult situation.
Yeah, this has been a great discussion, guys. Let's discuss another case. So we have a 48-year-old woman stricturing Crohn's disease on Remicade, no prior abdominal surgeries. You see her in clinic. She's had several months of postprandial abdominal pain, early satiety, some intermittent episodes of nausea, vomiting, and inability to pass gas. Normal CRP. Imaging showed a short segment, terminal ileal stricture. There was no evidence of active inflammation, and you're concerned for a fibrotic stricture, let's say. She undergoes a laparoscopic ileocolic resection, stapled end-to-side anastomosis. Initially, her post-op course was pretty unremarkable, but now it's post-op day 4. She's febrile, tachycardic, increasing leukocytosis. You get a CT. It shows a 5 centimeter by 4 centimeter loculated fluid and gas collection adjacent to your anastomosis. When there's gas tracking along the staple line, let's say there's more pneumoperitoneum than expected on post-op day 4, and you're concerned for an uncontained leak. So you decide to take this patient to the OR. How would you guys approach this case, and what are you thinking about when you're in the OR?
Yeah, I mean, as you already pointed out, this is someone that has an uncontrolled leak. They are septic from it. You really need to be in the operating room with this patient. So make sure they get some resuscitation, some antibiotics, and then intraoperatively, I'm opening in this case. You can consider putting a scope in just to take a look, but my suspicion is high. So I'm making an open incision. My approach to this is usually going to be resect the anastomosis and give them an endoleostomy. The other thing that's going through my mind is, should I redo the anastomosis? But someone that already leaked and already sick, has Crohn's disease, I would not reattempt that. I think they're better off getting an end, and then I can reverse them in a few months. That's how I approach it. I don't tend to repair the ileocolic resect anastomosis because I think a lot of times the leak is from the transverse staple line, and the tissue, I just don't think it's easily repairable and salvageable. And then how are you gonna test the anastomosis even if you divert them? Like, how are you gonna test it down the line before you reverse them from the diversion? I think it'll be hard to interrogate that anastomosis. So for my end of things, I would resect it and give them an endoleostomy.
Yeah, I would agree. That would be my plan going to the operating, would be resection with an endoleostomy, particularly because she has Crohn's disease is a big part of what that plays in my book. I really try for someone with Crohn's disease to not do a diverting loop ileostomy. Even on initial index resections, I'm either trying to do an anastomosis or a resection with an endoleostomy, and that would apply similarly in a take back. The reason for that is these patients oftentimes need further surgeries, can have further small bowel disease, and reversing an ileostomy, I don't love doing a side-to-side stapled reversal ileostomy because they start getting disease. That's a lot more bowel you have to resect for the next time they have problems. And I find that, there's data that shows that hand sewn, taking down these diverting loop with a hand sewn, which some people do, but can tend to have a higher rate of obstruction or stricture, and I always worry about that. So yes, I would be doing a resection with an endoleostomy here.
Okay. So now let's say the patient did not have a leak in the immediate post-operative period, but you're seeing this patient now in the ED 2 weeks later, worsening abdominal pain, fever, nausea, vomiting. You get a CT scan and imaging shows about a 4 centimeter by 3 centimeter abscess near your anastomosis. So what are you guys concerned about in this scenario, and what's your management for this patient?
Yeah, I think in that situation, this is most likely a contained leak. It's a perianastomotic abscess or a contained leak. If the patient is, you're able to resuscitate the patient and they're not in shock, I think you would try to percutaneously manage this with an IR drain. And with the idea that you may just find purulence, or you may end up creating a controlled fistula to this anastomosis. So I think you have to know that that's what may invariably happen, but you're trying to control the situation. And whether you're just draining an abscess or creating a controlled fistula, this will get this patient out of an acute situation that may be able to be managed, again, non-operatively.
Sure. And so I know we talked about this a little bit with colorectal anastomotic leaks. but now we are talking about an ileocolic anastomotic leak. Would you be concerned about similar long-term complications for these patients and managing these non-operatively?
I think the risk of stricture formation is still going to be there, and that's something you'll be able to assess endoscopically. You're not going to do a very good job assessing it radiographically with enema testing, but you can endoscopically assess this anastomosis down the line. And I think that's probably your biggest barrier if you're able to get them through without a reoperative intervention. But sometimes you would prefer them just sort of declaring themselves into a stricture versus just willy-nilly and back in there and resecting them, giving you an endoileostomy. Because there is morbidity to giving them a stoma. I mean, you may be able to get them through without another surgery and maybe dodge another step in this patient's course with a stoma and then a reoperation then down the line.
Sure. Yeah, you brought up a good point too, Dr. Trunzo, about stomas. So say you did do an ileostomy for this patient. Before considering reversal, how would you evaluate and optimize this patient, and how would her Crohn's disease play into the situation?
So the main thing before reversal is, make sure they recovered. Someone like this, I would make sure I give them probably 3 months before I go back in there. And then from a Crohn's standpoint, I want to make sure they have no evidence of active Crohn's disease in the proximal small bowel, and hopefully not in the colon either before I reverse them. So hopefully they've already had a colonoscopy before. If they haven't, I might do a quick scope, if I can, to take a look at the colon. But otherwise, that's kind of the main thing that I would care about, is making sure the Crohn's is controlled before I take them back to for reversal. And I'll most likely try to do an end to side in the Crohn's patient. Yeah.
Yeah, and I think, when you have a patient with an anastomotic leak, it's really important to be thinking about other ways you can optimize these patients. Traditional thinking, I think long ago talked about, putting these patients on TPN and keeping NPO, but it's actually really important to provide enteral nutrition to these patients, let people eat, get their strength up, physical and occupational therapy, rehab, control other comorbidities, really optimize and set yourself up for a success, get them stronger prior to taking them back. You don't want to take them back too soon. You want to control all their comorbid conditions, including the Crohn's disease, as you mentioned.
Okay. And then do you guys have any kind of closing remarks, really big takeaways for management of anastomotic leaks prior to finishing up?
I think that whenever you have a compromised anastomosis, I think it's your duty, whether you've had to divert them or how you manage them, that you try to, before you restore their continuities, that you optimize them nutritionally and you've reassessed the anastomosis for its integrity before you reverse their stoma or bring them back to the operating room. So those are the two big things. In the patient that has IBD, I think it's also important to acknowledge if they've been on steroids, if those things can be weaned off. Usually we didn't touch on it, but biologic therapy, more times than not, we try to keep them on their biologic therapy. There's some debate about some of that type of thing, and maybe that's not in the forum for this discussion, but sometimes patients getting a flare of their Crohn's will actually set them back, and removing all of their immunotherapy or immunosuppressive therapy is probably not in their best interest, but steroids will be impactful for their anastomosis reconstruction.
I guess my comment is, leak can be a emotional complication for a surgeon. And my PD, my program director from fellowship, will say this in a more colorful way, but he usually says, don't mess up mess up. And leak is not necessarily a mess up. It's just one of the complications that happen with the surgery. But that is all to say that when it happens, I think sometimes doing the right thing is going back to surgery and, resecting and giving them a bag. And don't be afraid to do that, because sometimes people try to manage it with drain antibiotics because they don't want to go back to surgery. And then you can kind of create a situation that festers and becomes chronic. And then the patient's functional outcome is not as good and it drags on for a long time, when you could have just gone back, given them a bag and just wait a few months and then reverse them. So that is all to say, in situations where that is appropriate, as tough as that is, I think, just doing that might be the right move. And sometimes just getting your partners involved, it could be very helpful to help you with that emotional decision.
Yeah, I completely agree. I think that's a real salient point, that you don't want to mess up the mess up. It is very emotional, and getting a second set of eyes is often really helpful, because you can easily try to talk yourself in or out of something. When you're unsure, usually the right decision is to go back to the operating room and create an ostomy when you're on the fence. But also remember that the patient's clinical condition is really the driving force of how to manage these anastomotic leaks.
All right. Really great discussion, guys. That's all for this episode. Thanks to everyone who was listening, and dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.